regards to health, this is data, right? It's data about
It's
the
data. It's data.
real world. So maybe we can talk a little bit about how your organization thinks about perhaps leveraging real world data in both at NOLA and maybe also at your actual your practice at the the name is CBCCA, so Carolina Blood and Cancer Care Associate. So maybe both at your practice level and also at the nonprofit level, how do you think about real world data, and how do you actually use it on a day to day, say not day to day, but operationally as well?
So very interesting. I should have mentioned something called CCORN, CCORN, Community Clinical Oncology Research Network. You can look up while we talk on ccorn.net website, and you'll see at the bottom my face without my beard. So being pragmatic and having habit of walking the talk, when I saw one of the reasons that leads to disparities and worse outcome is access to clinical trials. So without waiting for anything, I started this small LLC called CCORN, and our whole theme is bridging the gap between the real world use of drugs and the clinical trials. So we know that clinical trials are done at certain centers. We know that most of the rural Americans or underserved marginalized population do not have access to trials. So the trials may have data that may be skewed because biologically we all are different. Pharmacogenomics is different, other facts are different. So to bridge the gap, we started this small organization under the same roof like CBCCA and NOLA about 5-6 years back to focus on creating the real world evidence study. And I was more kind of excited about this because we also worked with the FDA and US Congress back in 2017 and 18 to have input into the 21st Century's Cures Act. So understanding the limitations of accrual in clinical trial for the appropriate representation of ethnic minorities, FDA expanded definition of some data algorithms where they say real world data collected post approval of the drug may allow pharma industry to add or change labels. And perfect example is there's a drug, I'm going to use the brand name because the generic name is a little difficult, called Reblozyl. This drug was approved by FDA back in 2020 or 2021 for myelodysplastic syndrome. And this was a COVID time, and it was excellent drug, but it was only approved initially for refractory anemia with ring sideroblast. That was the limited indication, a small subset of MDS patients. I saw the potential of this drug to help many more patients. So I work with my payer. Once again, if you work collaboratively with the payers, you can solve a lot of problems. So we had 3 or 4 patients who were visiting hospital repeatedly, and they did not have the disease that was approved by this indication. But I requested payer saying that it's a COVID time. I'm concerned about these patients going to hospital back and forth for the transfusion. There's a new drug that has a potential of being useful in this population. So the manufacturer worked with us. We used it in some patients and we could see incredible outcome. So then I went back and collected real world data on this drug, RWE. So there were 2 presentations at ASH where I was main person, 2 at EHA, 2 at NCCN, and we wrote an article. And as a result, the drug got expanded indication to all myelodysplastic syndrome patients. So I'm very big, passionate, and big advocate for RWE because, once again, because biologically we all are different, it's important for us to test the molecule that's been tried in, say, 200-300 patients for the approval to see how does the dose may be variable, how does the efficacy may be different. Another example is, look at the trastuzumab, one of the most commonly used drug for the breast cancer. It has double the risk of cardiotoxicity in underserved minority Black population. So coming back to, I'm a big advocate for the real world evidence, and it's very important that a drug that has not undergone full clinical trial with appropriate representation of the diversity of the population should actually carry out RWE studies to ensure that they are effective equally in all the patient population.
Yeah, I think that's a fantastic point that you're making, Kashyap. Is in some ways we're not blaming necessarily the pharmaceutical industry or
No, we are
pharma
not.
or
No, we
others.
want to help them.
Exactly.
We really want to help them so that they can find appropriate patient population, and if they need to do any dose variation, they can look at doing it. So it's actually going to complement a lot of pharma's effort. And it's also going to reduce the spending because now on one hand, FDA is becoming more and more vigilant about the ethnic minority presentation in clinical trial. But if a pharma company assures them that we will be carrying out what called coverage with evidence development, where we'll be adding the real world evidence study, RWE study or RWE data, it may enhance the quicker turnaround time. And when you look into some of the NTRK directed targeted therapies, they were approved with phase 2 trial and pending subject evidence generation with additional real world data.
Yes, and maybe